right, we're back with the Parent Confidence Lab podcast, and we are very happy today to have Andrea Gropman. Andrea is the director of Neurometabolic Translational Research Center for Experimental Neurotherapeutics, and she's the Mark Tamer Endowed Chair for Pediatric Neurology at St. Jude Children's Research Hospital. We are very happy and pleased to have Andrea here on the podcast today. Andrea, welcome.
Thank you. Thank you very much. Glad to be here.
All right. So we're going to really just open it up, really interested to learn more about your career and your work, which has spanned, it seems like several decades, really looking at helping children and specifically within the neurometabolic space. And so can you tell us a little about, your journey and how you really came into your line of work?
Sure. So my journey actually started with a patient. So I knew I liked child neurology, and I knew that I would eventually end up there, but I didn't know how or in what subspecialty, or even that I'd be on the path to rare disease. I never could have imagined that. So this was a singular patient that I met when I was actually a pediatric resident. And we had this very mysterious research unit. And patients with metabolic diseases were being treated essentially with chemicals off the shelf because there were no medicines. So this was back in like 1992, 93. And we didn't really have any therapies for these diseases. We barely knew what they were. And I was really impacted because it was a research unit. The patient there ended up having a urea cycle disorder. I didn't know 20 years fast forward, I would be working in that space. It's like come full circle for me. But she was severely impacted. They were trying some experimental therapy off the shelf. It had an unusual odor. The investigator, the physician scientist, you just had to fall in line. Like you didn't have time to explain things. You just joined the rounds and you just listened and took in everything and learned all these metabolic pathways, and it worked. And then, I found out only years later that this became a medication. It became a treatment. At that time, children were dying from urea cycle disorders. That was about 20 years ago. Now they're living into adulthood. We even have CRISPR for baby KJ, where they corrected his molecular defect. So it's really been a full journey. And I think as a child neurologist, understanding how the brain was affected in these disorders really stuck with me because the bar was very low. Even as there were therapies, the patients were living longer, but they weren't living to their full potential. And I think, the parents really demanded more. And it was this working with patient advocacy way back that really, I felt my why is, I really need to understand the brain, how to improve the life for these patients beyond just the fact that they were living longer, but wanted them to live well and try to understand it. And so essentially my life's work was focused around understanding the brain in these rare metabolic disorders and how we can effectively make patients feel better and raise that bar. And I owe a lot of that to working with patient advocacy early on, and I'm really grateful that I was introduced to working with families, and I think it's essential to move the research forward. It's a partnership. And so right now, and for the past 20 years, my research has focused on using different types of MRI imaging to understand the how and the why of the brain in these rare metabolic disorders, mainly with urea cycle disorders, but also with other rare metabolic disorders as well. And I've been doing that for about 20 years, and we're learning a lot. We're learning a lot of things. We're learning that patients who previously were thought not to have symptoms or mild symptoms actually would benefit from therapy. So it's been very exciting, but it's been almost like pushing a boulder up a hill because at the time, the focus was just on it's enough if the patients live. And I was really pushing that, they really need more than just longevity. They really need quality of life. And so I think in the last decade, when rare diseases came on the map, it was a hard push. But now I think that a lot of groups are aligned, a lot of stakeholders are aligned with rare disease, and there have been an explosion of therapies over the last 5 or 7 years. So I'm excited about that.
It sounds like you're doing such kind of cutting edge work in this field, and thank you for all that you're doing. What kind of exciting discoveries have you made in these last kind of 10 or 20 years that really keep you going?
So I think a few things. One is, working, and I'll use my example in urea cycle disorders because I spent about 20 plus years of my career on that, is we have one particular type that's X-linked, meaning that the gene is carried on the X chromosome. So all males have some manifestation of the disease because they only have one X and they have one Y. The X they get from their moms, the Y from their dad. Females have two X's, and so if they have the mutation, there's variability in how they can present. And in particular, we used to call women who had the mutation on their X and passed it on to their sons as carriers, right? And so they were often taught that, you're just carrying this gene that you're passing on, but you yourself don't have any symptoms. And, the more I worked in this group, the more I attended the patient advocacy conferences and the yearly patient conferences, I realized that, that may not be the case, is that these women were describing symptoms or I could observe their behavior and interactions that were on the milder end, but they definitely didn't seem like normal, symptoms. And so we were actually able to do a study using a longitudinal database that we collected as part of our Urea Cycle Consortium study that's been going on for 20 years to show that, in fact, their symptoms changed over time. So there were two key points in time where they could present symptoms, and a lot of this was related to the hormones, to estrogen. One was during puberty, where we saw increased rates of anxiety and depression in the females, and the other was menopause, the peri and menopausal and postmenopausal, where women who didn't have classic symptoms were actually now noted to have symptoms and at risk. So that really changed the paradigm of how we counseled them. It legitimized a lot of their complaints. I think after a while, when you bring something up to your doctor and they say, oh no, it's because you're stressed taking care of an ill child, you don't mention it anymore. And so, they would just dismiss it as it's all me, it's in my head. But now, it's not in their head and it really is a minor symptom. So these women are benefiting from having treatment, being on low protein diets, etc. I say that's one. The other is recognizing that we can identify some of these carriers by neuroimaging, so that there are certain sequences on MRI scan that can allow us a look, if you will, into the biochemistry of their brain and recognize it. And I think the last thing is how this impacts their day-to-day life. So, and just being observant and listening to what families and patients tell you. Maybe 10 years ago, I was at a patient advocacy conference, and a lot of the women with this urea cycle disorder, the X-linked version, were talking about driving and difficulty they were having with driving. And so because driving requires focused attention, cognitive flexibility, everything in your executive function, which was a problem. We knew that. We had done pen and paper testing on that. We had done functional MRI on that and shown it. We decided to develop a paradigm for driving that we could test the patients and see actually what was happening in the brain, not so that we would say, yeah, you're not a good driver, get off the road, but more so so that eventually we can develop a remedial driving program. Because now that the patients are living longer, driving is so essential for independence. And if you don't live in a city where you have access to public transportation, that really impacts where you work, where you live, what activities you can take your children to. It's very empowering to drive. And I know that because my own mother had an eye issue and was not able to drive in her 40s. And, not only did it impact her independence, but also my brother and I growing up, in terms of activities we could partake in, we always had to do them if a neighbor was doing them so we could get a ride with them. So I realized how important that was to being independent. So we used our knowledge and some of our imaging technology to actually design a driving paradigm, which we hope to roll out this summer.
Wow. I'm sure that will go a long way towards helping them achieve that full independence of driving, which is really essential. One thing that you mentioned is really patient advocacy, and the fact that you're listening and learning to a lot of the patients, with different conditions. And a lot of times, it sounds like you're going to different conferences and you have different ways that you gather that data. But could you just expound on the importance of patient advocacy and making sure that they're advocating for themselves, but also letting you know what's going on? And then also, are there any kind of standard ways to actually collect this type of phenotype data, the observational type of data that is so critical to coming to those realizations that you're doing?
Yeah, absolutely. So that's about 3 or 4 questions in one. So I think with regard to patient advocacy, I'm really glad that I was part of the Urea Cycle Rare Disease Consortium, which was actually started in 2004. It was a congressional mandate to study rare diseases in large consortia, and it required the partnership between physician scientists and patient advocacy. So right away when I joined, I was very junior. I had just finished my fellowship. I was put into that mix. And so it just seemed very natural because a lot of the research we thought was important, or my colleagues, just didn't resonate with the families. And so, it really taught me to listen to what's impactful and to work within that space. And I think also the patient advocacy has evolved. And I've seen it on different levels, the different patient advocacy groups I work with, some more at a grassroots level and some very professional with international standing, their own funding mechanisms. And the people within the groups come from everywhere. There are parents who are scientists, parents who are lawyers, patent attorneys, work in Congress, everywhere. And I think that really adds to the richness of the group and what they can provide. And they speak up. One voice may not go anywhere, but the voice of a group and then alignment with other advocacy groups has really been impactful and has really pushed drug development. I know with the Urea Cycle Consortium, 4 drugs were approved over the time I've been involved, and a lot of that was in partnership with patient advocacy. So I think that they can be a really powerful force for moving things forward and making change. And I try to stress to junior physicians that, they need to get involved as early as possible in their careers with patient advocacy, not only to kind of look and listen and see the phenotypes, but also to understand the day-to-day, because we see the patients for half hour, an hour in our clinic, but we don't know what happens at night, a child who doesn't sleep all night or is having seizures all night, the impact that takes on the family, why families make certain decisions about the things they do, and how it impacts the rest of the family, the siblings. So I think it really gives a nice snapshot to see also the children in a naturalistic environment, how they interact with their peers, how they interact with their family and siblings, what they do, what they don't do. I think it's just really important to see that. I think that's 2 of the questions. I don't recall the others, but maybe I hit them all.
That's okay. That's okay. And for those listening, and actually even for myself, could you tell us a little bit more about what is the urea cycle that you study?
Yeah, sure. So it's a group of 8 enzymes. So enzymes basically do things in the body. They either produce a product or break down something or build something up. The enzymes are proteins. And so in this particular disorder, the problem is breaking down proteins in the body. And usually you want to break your proteins down into nitrogen, which is used in your body for building blocks. And in this case, the nitrogen, there's a block. So there can be a block in any one of these 8 enzymes, and the nitrogen gets diverted and makes something called ammonia. Now, this isn't the ammonia that's in cleaning fluid. This is actually a chemical compound that can go to the brain. And when it goes to the brain, it can cause changes in alertness. So some patients, if they have a high ammonia load, can go into a coma. They can have seizures. They can have changes in their behavior, almost looking like psychotic. It can affect your ability to learn and think. And so depending on how severe the enzyme deficiency is, and these are things you're born with. So these are what we call genetic hereditable disorders. So you're born with them. You can pass the genes on. They're not typically sporadic, meaning it just happens in that person. Usually there's a family history, although that person may be the first in their family to be identified, but then they're at risk of passing on genes to their offspring if they're able to have offspring. And so the main issues for treatment are lowering the nitrogen by lowering the amount of protein. So these patients are on a very restricted, in some cases, protein diet. So at the very severe end, these patients may only be able to have 8 grams total in a day, right? So you take something like chicken that's got 27, so not even like a third of that in a whole day, spaced out between meals and snacks. On the upper end with milder deficiencies, they may have, less of a restriction. And then for those that can't manage it just by diet because they would have dietary deficiency to be so low on protein, they also have to take medication, which basically acts as a sponge and sops up that extra nitrogen so it can't be made into ammonia. And, the first generation of medication, the patients were taking like 30, 40 pills a day. It just was untenable. It gave them nausea. It gave them some of the symptoms they actually had with the disease. So many patients would be non-compliant. And then the first generation of treatment, which is the one I experienced when I was peds resident at Johns Hopkins, it had this abnormal odor. So I could walk into that research unit, smell it, and say, oh, okay, there's a urea cycle patient here. So you can imagine the social stigma of walking around with this type of drug that when you sweat, it just seeps out of your pores and it smells horrible. Luckily, with the help of patient advocacy and the Urea Cycle Consortium and NIH funding, we were able to get to second and now third generation of these nitrogen scavengers that require less in terms of the amount, don't have the same side effects, and don't cause that abnormal odor. But, they're very expensive. And a low protein diet is not easy to maintain. There are some special foods, but the medical foods also cost a lot of money, and formulas. And, depending on the insurance reimbursement, it may be difficult to get these universally.
We know in the rare disease space, our own daughter had a rare disease that's still yet to be even diagnosed. But we know that a lot of times the funding just really isn't there, especially that it really impacts just a small percentage of the population. But you said in the past, a lot of times metabolic patients were getting just off the shelf drugs. Has there been any change now where, those that are living with rare diseases have a better chance, to have, some kind of better prognosis across them?
Yeah, definitely. But it's still not equal. I mean, access to the drugs is still difficult. And then if we step outside of the US even and go into like Latin America, it's almost impossible. The mortality rates for the diseases that now we see patients living into adulthood are still like on the order of, 30% for some of these urea cycle disorders. I remember being struck by that when I was at an international metabolic conference and saw a poster from one of the Latin American countries. And I thought, wow, like we seldom lose children with this particular urea cycle disorder in the US because they don't have access to the meds and they don't have access to the specialized formulas. I think now it's difficult for the adults. They seem to fall out of that safety net because depending on the type of work they have and what type of insurance coverage they get, it's been difficult. Once we have one product went off patent exclusivity, the generics may not work as well for some of these patients. And they have to prove that they're failing before they can get the brand name, which is a risk for these patients because if they do have a high ammonia state hyperammonemia, that can impact their brain. And so why would you want them to fail before you give them the brand name? It just seems, the backwards way to do it, but that's what we've seen with a lot of drugs in insurance company, even for cardiovascular disease, for cholesterol lowering drugs. If you fail, then we'll give you, the one that your insurance company doesn't want to give right away. But why give that person that period of vulnerability? With the high cholesterol, they could have a stroke during that time that they're waiting to fail so that their insurance company can then approve the more effective product. Yeah.
And with urea cycle disorder, how, give us the numbers, how many folks in America are diagnosed with this? And then is it something like, as a parent, if you're worried, your child's showing some symptoms you're not sure about, is that something that's diagnosed before birth, at birth, after birth? How does that work?
So all of the above. So we have some urea cycle disorders like baby KJ who got the CRISPR gene therapy, he had CPS1 deficiency, carbonyl phosphate synthetase type 1. That's pretty rare. It's 1 in 500,000, 1 in a million, okay? And we have another one, arginase deficiency, that's 1 in a million. That one just recently had enzyme approval on February 24th, pegylated arginase for that group. Ornithine transcarbamylase deficiency, which is the X-linked one I was talking about, that one's about 1 in 40 to 70,000. That would probably be the most common. And then the others are in the range of about 100, 200, 300,000. So they're rare. They're pretty rare, some more rare than others. I think, some are not diagnosed on the newborn screen. So arginase deficiency would be, CPS1 wasn't, which is why the period from diagnosis to treatment was quite rushed and actually protracted for baby KJ because they had to verify the diagnosis. There are some biochemical labs that can give you a sense, but they really needed to know his mutation to know if they could make, do the CRISPR against his particular mutation, because his was, specific to his and not to everybody with CPS1. It was a personalized genomic therapy. Sometimes there's a family history, so you can have prenatal diagnosis if there's someone with a known mutation that's been characterized. In the female so-called carriers, about 10 to 15%, we don't find a molecular mutation. It's based on the clinical and also the biochemical findings. But I think if any child has unusual symptoms, they should be referred in and some workup should be done specific to what they're presenting with. Absolutely.
If a child didn't have this diagnosis, or if maybe you're in a country where it's not as commonly tested, how would they present with that particular?
Well, it would depend. So I've been talking a lot about OTC deficiency. Typically, the males would present, if it's severe in the newborn period, with lethargy, so poor feeding and sleepiness, unable to wake them up, more sleepy than a typical newborn. They may have decreased urinary output and dehydration, and then they may actually be having seizures or lapse into coma because of the high ammonia, particularly in the brain. Milder may be behavioral issues, a lot of vomiting, food aversion, particularly protein-containing foods. I think on the other end of the spectrum, arginase deficiency presents more like a cerebral palsy type picture, but after a period of normal development. So the child is born fine, there's no birth injury or asphyxia, they're walking, and then they slowly lose those skills to the point where they're no longer walking, their head circumference actually shrinks, the brain is no longer growing, and they may lose ability to speak or speak in a very difficult to understand way, we call it dysarthria, and look like they have cerebral palsy, but not having started that way. It's a progressive disorder. And then some of the others in between, more cognitive issues, seizures, autism-like features. And then the adult onset of these disorders may present later in life because they've somehow managed to restrict their protein on a subconscious level. Having had an experience with feeling ill with large amounts of protein, many of these patients may self-restrict. And then usually a virus or surgery or some second hit may cause them to have a metabolic decompensation. The adults typically present with more psychiatric symptoms, belligerence, psychosis, but some are diagnosed with having bipolar disease. So it looks very different. Many of them are not recognized early on because they're being treated for alternative diagnosis, like a psychiatric diagnosis. And then I think any type of certain medications can accelerate the presentation. We've had athletes with OTC who've had surgery and been put on steroids, and that causes decompensation, who've never had symptoms before. Certain psychiatric medications like valproic acid or Depakote, that's sometimes used as a mood stabilizer, can put somebody into a metabolic decompensation, even though they might have had minor symptoms growing up. An infection, a severe infection, fasting, prolonged fasting, or viral infection. And then postpartum, I should mention also, women So I think that's also a missed opportunity for diagnosis, is some of these OTC females who have given birth, because there's a rapid catabolism after the delivery and uterus involutes, and there's a lot of protein exchange in the body, is they present with a very severe like postpartum psychosis and depression that's beyond, what would be considered appropriate. And so they need to be investigated as well.
So it sounds like, one has to be, as a parent, very vigilant on how your child is progressing and, what you're observing about the child. And then as an adult, I guess that's a lot of self introspection. But in terms of being a partner to a provider or to a researcher, in your case, how can parents, be better prepared to know what to look for? Because we know that this seems to be rare, and many times maybe even pediatricians wouldn't necessarily educate that parent on what might be the possibility. But how can parents be better prepared to really understand if their child has an OTC? And by the way, I didn't get the acronym OTC. What does that stand for again?
Ornithine transcarbamylase deficiency.
Okay.
Yeah.
All right.
Probably easier to say OTC.
Yeah. OTC. Yeah. We'll stick with OTC.
Yeah. So, I can say the words easily, but they're a mouthful for most
absolutely.
people.
So what can parents do to educate themselves?
Well, luckily a lot of these patient advocacy groups are pretty sophisticated and have conferences and also a web presence, whether it's a Facebook group or an official website. And I find that those are great sources of information, particularly for newly diagnosed families. We encourage anyone with a new diagnosis or transitioning, so going from infancy to childhood or childhood to adolescence or adolescence to adulthood, to attend the conferences, not only to learn from us, but to learn from other families who have lived the life and, have more day-to-day tips than we would. So I think many of these conferences are full of information. Disease 101 type lectures are given, small groups to discuss the different stages of life and the challenges. Updates in medication and new therapies are often part of the conference, and also the opportunity to interact with the disease professionals in a less restricted environment. So you don't have the time constraints of a normal office visit, but you can chat with them. I know I've been to some family conferences like for mitochondrial where they have the Ask the Mito Doc. And so patients and families can come and sit at a table with us and ask questions or bring lab results and ask us to explain things. So I find that that's very empowering for the families, and also the content online for many of these patient advocacy organizations. Their websites have a lot. Some of them have recordings from previous conferences. Some of them have, potential dietary plans with low protein, or definitions and medications and dosing and things like that. And I'd say the same for physicians too, because if somebody is taking care of a patient with these disorders, likewise, they should go to these sites as well to learn. And, I say to a family, it's unlikely that your pediatrician will be an expert. Great if they are, bonus. But, what would distinguish a good pediatrician from others is their ability to learn with you and to find the resources and to partake of the knowledge that is out there already, and not to feel, I don't know what the right word is, but, to be accepting of information that the families bring. I know I work with another disorder, Smith-Magenis syndrome. It's a chromosome disorder, and their patient advocacy group actually put together a roadmap, if you will. And because it's multi-systems involved, there are checklists of what the pediatrician needs to know. Like, they're at risk for hearing loss, they need an audiology screen, they need their thyroid checked, they need scoliosis screen because in puberty they can get severe scoliosis. And it's like a point by point, bring to your pediatrician and say, my child's 6, my child's 13. These are the recommended medical surveillance that's been put together by the experts in the field. And I think a pediatrician who is not accepting of that, you need to move on, but they should be working with you, especially if they don't know the disorder, and say, okay, like the, patient advocacy group and also the scientific advisory board for this disorder feels that, this patient needs this or that or a vision screen and, working together with them. I've seen that be pretty effective as well as it's this medical roadmap of what to do. And they've also put together for the school, like Fragile X has a great resource for the schools and services. So I think there's a lot of information out there and hopefully it's accessible to most people who, have access to the internet and all kinds of digital technology. So that's much better than it was 20 years ago when I first started in this field.
Yeah. I guess if I can ask one follow-up question to that is, the period that I'm kind of referring to is really that gray area, that pre-diagnosis kind of period where we know that odyssey towards even getting a diagnosis might be very confusing, worrying, anxiety filled, where a child's not peeing exactly, or maybe rejecting chicken, or maybe throwing up, but they're not necessarily sure what's going on because throwing up could be a multitude of factors. What do you say to that parent that's living in that cloud of, gray area, where they don't have any really basis of where to go?
You got to keep going and start with the pediatrician and then demand for the follow-up. If the symptoms are neurologic, see neurology. If it doesn't really seem to fit at all, genetics is usually a good place to start because they try to take all the pieces and make sense of it. I'd say, just keep pushing. If it doesn't make sense, you need to keep escalating. I mean, I had to do that personally. My daughter had food allergies and I knew something was off and I wasn't getting the answers from my original pediatrician. And I said, no, I know there's something going on. I didn't know exactly what it was at the time, but then it was making sense that it was allergy. And I just kept pushing. And, even as a physician, I was told, you first time mom, you don't know, babies throw up or they have colic. And so I think that just trying to find the answer any way you need to is the thing to do. And, if you need to leave a pediatrician to get that answer, you need to do it for your child. Don't feel badly about it. I didn't. I fired my first pediatrician. And then years later, I told him why. After I got the diagnosis and things were under control with her, I felt it was important for me to tell him what actually happened so that if the next family came, he would recognize that. So,
what food allergy did your daughter end up having? If you don't mind me
everything, pretty much everything except for like 3 foods early on. Yeah. But it could have been a metabolic disorder because it was mostly all proteins, but it was also other things as well. So, in the beginning I didn't know, but I knew something wasn't right. And I needed to find that answer. And, it fired a couple of people along the way, but we got the answer and got the formulas. Yeah. And it was difficult too, because our insurance didn't cover the formula and I had to pay out of pocket. So I understand, what that can be like for other families as well.
Yeah. And obviously in our case, in your case, there's just so many stories where it's like deep down in our gut, we know something is wrong and we're not getting the right answer that fits the mold. And I think it's very important for parents, especially new parents, to listen to that because it's usually your body telling you that something is still off.
Yeah.
And other people will hear it and other specialists will see a different approach.
Yeah. And a parent's intuition oftentimes is correct, which yours was. And that's more often the case than not. Even, you as a parent will always have the best interest in your child at heart, and no one else has more interest than you, right?
And you see them 24/7, right?
Exactly. It's that extra data, right?
Yeah.
Yeah. So sometimes the story is the data, right? So I'm actually also writing a book on my experiences taking care of patients and families with rare disease and lessons it taught me. And in each case, this was the data. The stories were the data because maybe the lab tests were normal, the MRIs were normal, whatever test we did was normal, but the data was in the story and it just wasn't measuring up. There was definitely something there. And listening to the parents' intuition and their journaling or whatever they brought to the visit, because we only saw the child for just a snapshot in time. So we didn't get the whole picture. Yeah. It's very important.
Yeah, that was definitely the case with us, was that every doctor had a different opinion, a different, prognosis, a different idea about what she could have. And there would be moments where I'm like, that's just not it. I just really don't think that's it.
Yeah.
Like, I don't think that it's XYZ. And what happened with us is we would often disagree. And he would be like, I think it's this. And I'm like, I just don't think. And it's a difficult place to be, And someone asked me, like, what do you tell a parent when they're second guessing? I'm like, second guessing is part of being a parent. Like, we don't always know. And you need to talk to people. That's often what gets you to talk to the right person, is you keep questioning what you're hearing, and you're trying to find someone else who might have a different understanding of the situation. So I think it's part of being a parent, and it's important for parents to keep searching and looking for those answers. And, I had something similar with my first baby, and just a lot of spit up and couldn't figure it out. And just somebody mentioned, oh, when I was having that, I just stopped having dairy when I was nursing. Why don't you try that? And I did, and then everything got better.
Yeah.
And it's amazing, like these little tips that can make a big difference.
Yeah, and I think the way medicine has evolved has really prevented us from hearing these stories. The focus is more on the efficiency and our RVUs and, how many patients we can squeeze into a day. And I know that I, for one, went into medicine because I enjoyed the stories. When I was a resident, I would go back at the end of the day because then I knew dad had come from work and maybe a sibling was there, and just chat with the families and see what else I was missing. And there's just no space for that now because, everything is more like shift work. The residents have restricted hours and they're not allowed to stay beyond their 80 hours a week or whatever the case may be, and they leave. And then there's a handoff to the night person who doesn't really know the family. They're just keeping things in check till they hand the patient back in the morning. A lot of the subspecialists come in the afternoon after their clinics. If they don't have fellows, the attendings come. And the day shift is gone. So they don't hear these discussions, how the GI puts this into perspective, or what rheumatology thinks, or cardiology, which, may have different views. And so I think a lot of that is lost on the newer generations. And having been someone who grew up in medicine where it was more about sitting with the families and the stories, to this is just, it just doesn't resonate with me right now. I don't like that. And I feel that everybody gets shortchanged, the families for one, and also the doctors and their growth and development. The humanism part of medicine is being lost. So
We could agree with that.
Yeah.
I'm curious, just going back to the patient advocacy side and really, parents, being that advocate and that squeaky wheel almost. Outside of your own experience, can you, recollect an experience where there's been a time where that mom or dad was kind of kept saying something, but ultimately that story, the answer lied in that story? Is there any kind of specific anecdote that you can remember?
Oh, yeah, many. And many of those are the chapters in my books. I never wrote anything down. I just didn't have the time, because you were just speeding ahead to get to the next thing. But when I sat and thought about it, I actually was gearing up to write a screenplay. So I had taken this class called Screenwriting for Physicians, and then COVID struck. I was working on something. And then after COVID, things were different. And my screenwriting teacher said, oh, don't write a screenplay. There's so many, and Hollywood's a mess and all this post-COVID. Just write a book, and nonfiction is in. And I didn't know what to write about. So I said, well, why don't I take this story and others and put that into a book? And then it just came, nothing written down, just thinking, oh, what about this case? And what about this case? So I think in many of those cases, that was the clue, was the story of what the family was saying. And also remembering cases, because these stories took me through also a theme of how genetics and genetic testing evolved. Because in the early days, we didn't have molecular testing, we didn't have exomes and genomes. And so we would just document facts and try to put things together, and maybe there was a diagnosis, there wasn't. And then in about 2013, when exomes started hitting the scene, we were diagnosing disorders that we hadn't diagnosed in the past. Many we didn't even know what they were. And we were defining them as we went. And now with Whole-Genome, more diseases have been described, including the Renew story, which probably accounts for a quarter of kids with developmental disabilities. It's that small RNA variant that's been described a couple of years ago. There's a big paper on it, and immediately an advocacy group formed around that. They had a conference last summer, and they're pushing for therapy. So I think the pace of things have really changed, but the thing that is the same as the stories and the patient stories is the data. And so trying to weave those stories in with how things advanced in medicine is what I'm trying to achieve. But I think the stories were always there, right? It's just now we can diagnose more easily because we have the tools. So it was actually more important back then to listen to the stories, but it's still important now to listen to the stories because we're diagnosing new disorders every day with the technology. So yeah, definitely several of those scenarios, the data was in what the family was saying or the patterns that weren't, recognized, or you couldn't quantitate with some kind of laboratory-based test or an MRI.
And what were you mentioned that sounded really interesting right there, just kind of briefly on the surface, this news, the RNA that just came out. Can you talk more about that?
Yeah, so that's the Renew. They're these small RNA-based disorders that cause kind of a non-specific developmental disorder. I actually had 2 patients who ultimately were diagnosed. They both had epilepsy and intellectual disability. There's some facial features that were similar across the spectrum, but it's estimated that, up to a quarter of children with undifferentiated developmental disabilities plus or minus epilepsy may have one of these, Renew 2, Renew 4. And they weren't diagnosed until we got to whole genome sequencing. So many of these were diagnosed on a research basis, and then now they can be diagnosed clinically. So, and again, they mimicked other things. I remember, does this patient have mitochondrial disease? No, that all checked out. Is this, it looks like Rett syndrome? No, that checked out. So they looked like other disorders that had been well characterized, but everything came back negative. And so that's also an example of pressing forward. And now the family's advocating, if you have a child who has an undiagnosed developmental disability, ask your doctor specifically to send the whole genome or, test specifically for this disorder. So I think, and the fact that advocacy group sprung up really fast and had already organized a conference and they're pushing for therapies, shows the power of that partnership with the families and the physician scientists.
Yeah. We've actually know that experience pretty well, where the doctor ordered the whole genome, but then an insurance company denied it, and for payment reasons and everything else. And so, it sounds very straightforward, but we know in reality it can be complex.
Yeah.
Even if we know what the right procedure should be done.
Well, I mean, sometimes, if it seems like there is a diagnosis there, the physician can refer you for research-based testing. So initially this was part of the Gregor Consortium, which was a research-based whole genome sequencing at certain academic centers. And so that's how the first patients were diagnosed, was more on a research basis, that every test they had molecularly failed to find a diagnosis, but there was a high suspicion. So sometimes, and sometimes these labs too, I know GeneDx used to have this Odyssey program where you could, get like a free exome or genome at the time, but you had to submit it and had to be approved based on the likelihood. So I think there are some loopholes that can be done on a research basis. Of course, they have to be confirmed in a clinical lab subsequent to that. But I know it's an access issue, and it's even worse with adults. So if you have somebody who's in their 60s or 70s who had intellectual disability their whole life, and the family wants to test because they don't know the genetic implications for maybe their other children who, want to have children, or someone else in the family, many of these older individuals, they didn't have chromosomes even back then. If they're 70 or they're at least above 65, they didn't have chromosome tests back then. And so, they've never been tested. And so there's still an argument, because Fragile X is very heritable and can be very mild in some patients. So it's still worth pushing for a diagnosis in these older individuals with intellectual disability, because it can inform the family risk as well as what lies ahead for these individuals. Are they going to outlive their parents? Then what happens to them? Or are they a risk for cancer or other disorders? It changes their medical management. So I'm a big advocate for testing across the lifespan, even into adults, especially if they didn't have access to that testing because it didn't exist. And you can imagine the insurance companies, they're not going to want to approve a whole exome or genome on, like a 68-year-old. So
Yeah.
what's the point, right?
Right.
But it's really
Right.
important for the family counseling as well.
Interesting.
So hopefully that changes, but that's going to require advocacy and legislation.
Yeah, and circling back kind of to misdiagnosed or underdiagnosed, when you're talking about OTC and postpartum and some other psychosis demonstrations, how many of those do you think? I mean, roughly, there's probably not a statistic, do go undiagnosed that are just like, oh, you're just having postpartum psychosis, and nobody finds out that it's OTC related.
Well, I mean, we don't know the numbers because they're not diagnosed, but I can tell you that when working closely with the National Urea Cycle Disease Foundation, we hear about the misdiagnosis when it leads to a tragedy. So I'd say at least 3 to 4 deaths of usually OTC, adult-onset each year that went undiagnosed or ignored. And I know a few psychiatric cases where the patient was not investigated even after they had an adverse effect to a medication that shouldn't be given if you have urea cycle disorder. So we know the bad outcomes.
Right.
Yearly there are several that at least we know about, and then there may be people who die who never had the diagnosis, but at least the ones that we hear about, it's at least 3 to 4 too many each year.
Well, thank you so much, Andrea. We really appreciate it. I've certainly learned a lot, and I think Christina did as well. But, for our listeners out there, and many of them are parents, knowing what you know now about either your career or even looking back on your own parenthood journey, what advice would you give for a parent out there, whether they're a new parent or a parent of a teenager, that some advice that you wish you knew then that you do know now?
Yeah, I mean, I think it's really important to advocate. We've been talking a lot about advocating if things don't feel right, and you shouldn't, take it that, you don't have the medical sophistication or you're stressed because you're taking care of an ill child, that you can't also have the same symptoms, especially if it's an X-linked disorder. I think, it's just human nature as parents that we want to find out what's wrong and see if there is a fix. And especially now because of personalized medicine and the pace of accelerating treatments for rare diseases, that not only are you helping your own child, but you could be helping the whole, field with your advocacy. And I think joining the legitimate advocacy groups when you're ready. Not everybody's ready because they have to grieve in their own way. And sometimes seeing patients on the severe end or the milder end may trigger something. So I think feeling like you're not alone, that this is a journey that other patients and families have gone through, although the diseases may be different, but that it's a journey worth taking. And for many reasons, you help your own family, you may help other families along the way and push the field forward in ways that you can't even imagine at the time. I think it's very empowering also to be an advocate, and it shows you skills that you may not know that you had. I think it can really awaken something within.
I love that. And, I think to our own journey, and because of Eva's illness was so rare and, pretty much unknown, we want to get her story out there because we said, like, maybe there's a baby in Japan presenting with the same exact symptoms, and maybe they can do something different with that child, that baby, that they couldn't do with Aviva. So that's kind of the challenge of our place because it's so rare and unknown. But, we're always trying to put her story out there just so that other parents and other doctors, other researchers know that there's this case that kind of went completely unknown. But maybe the symptoms she's having, other babies are having. So
absolutely. Yeah. And I've seen advocacy groups align across the globe. And there may be 3 cases in the US and 4 in Brazil or 3 in Japan. And it's really that outreach that helps also the physician investigators learn about the disease, because the more we see, the more we understand what the aspects of the disorder are and think about ways for therapeutics.
Yeah, wonderful.
Well, thank you so much, Andrea. I really appreciate your time today, and thank you for educating all of the listeners out there. You're doing a really amazing service, and best of luck with all the research going forward.
Thank you, and thank you for having me.
Okay.
Bye-bye.